Thrombosis, defined as the formation of a blood clot within a blood vessel, is ubiquitous in medicine and society. It can either be protective, stemming blood loss following an injury, or harmful, even life-threatening when developing without good cause. Thrombosis that occurs within an artery is the proximate cause of heart attacks and strokes, affecting 750,000 and 1 million persons respectively each year in the United States. Blood clots within the veins cause deep vein thrombosis, also known as venous thromboembolism, and pulmonary embolism, with up to 600,000 cases yearly and a 30% case fatality rate if untreated. Thrombosis, whether occurring in an artery or a vein, is often preventable and treatable with medications delivered orally, subcutaneously, intravenously, or locally, using specialized catheters that can be employed to physically extract the blood clot. October 13, 2014 has been designated as World Thrombosis Day, a worldwide initiative aimed at reducing the significant disease burden caused by thrombosis. The overall goal is to raise much-needed awareness and action through public and professional activities. The University of Cincinnati College of Medicine and its faculty and staff within the Heart, Lung, and Vascular Institute are intimately involved with the investigation, prevention, diagnosis, and treatment of arterial and venous thrombosis. So too are faculty and staff within the Neurosciences Institute and the Cancer Institute. Over the next several minutes, you will learn more about groundbreaking and innovative work being performed right here, right now. I am joined today by Dr. Joseph Broderick, Director of the University of Cincinnati Neurosciences Institute, and Dr. Bill Barrett, Director of the University of Cincinnati Cancer Institute. Gentlemen, welcome to Scholarvision. Bill, we're going to talk a little bit about thrombosis, something that affects all of us, whether it be in the neurosciences and oncology and cardiology. Maybe you can just share a few thoughts about what thrombosis actually means and how it manifests in the kind of patients that you would see on a day-to-day basis.
Well, within cancer, often there is a hypercoagulable state where patients are more prone to thrombosis, and that can be an issue with pulmonary emboli that people get in the presence of cancer, strokes that people get as a manifestation of having cancer. In our field of radiation oncology, we're very concerned about vascular interactions with radiation therapy. And side effects from radiation therapy can be acute side effects occurring during treatment and shortly after, which are a function of effects of radiation against rapidly proliferating cells, whether it's bone marrow stem cells or mucosal cells. Late radiation reactions are on a vascular basis, and it's from an endothelial fibrosis that small blood vessels get, and tissues become ischemic, and so that's a real issue with radiation therapy.
Yes, and over the years, I know there's been a lot of discussion about using certain types of preventive therapies because the patients that you see are at such high risk. Are we at a point where we're routinely using prophylactic therapies?
Well, within radiotherapy specifically, the biggest emphasis is on minimizing the amount of normal tissue, the amount of normal blood vessels that receive the radiation. In terms of medical management, antithrombotics, thrombolytics aren't routine, used in certain situations, but not routinely.
Yes. So even though we know those patients are at very high risk, we just haven't reached that point where we feel that there should be preventive anticoagulant therapy, antithrombotic therapy across an entire spectrum.
We haven't done it routinely. We do screen for situations where we think that we may have incurred fibrosis, whether it's the carotid artery stenosis or coronary artery stenosis. We definitely screen for those things.
Yes. Now, Joe, obviously thrombosis has a major impact on your world as well with stroke. Maybe just touch upon a little bit, based on your experience, what this really means at the population health level and then at the patient by patient level.
Well, first of all, stroke is is really several different diseases, but it involves blood vessels that supply the brain. So 85% of the time it's a thrombosis or an embolus, a clot that breaks off and plugs a distal artery that's going to be causing a stroke. The other 15% of the time it's rupture of an artery and bleeding. In that case, you actually want thrombosis because you like to stop the bleeding. So we have both sides of it. Too little thrombosis when you need it when a ruptured artery, but also, and more commonly, having a blocked artery. And one thing that's different in stroke than, let's say, cardiology, where the primary problem is a thrombosis and then an artery that closes in the coronary. In stroke, the clot can form in multiple places. So, and most of the times it's actually an embolus, a clot that comes from somewhere else that plugs the artery that causes the problem. So probably about a quarter of subjects with stroke have actually a clot that comes from their heart, one of the chambers of the heart. And they can have clots that come from arteries in the neck that go up to the brain. Then you can have plugging of the small arteries in the brain. And even we can have where the clot starts, let's say, down in your calf, and a calf vein goes through the system and goes through a hole in the heart and then goes up. So it's a lot of different places that the clot can start from, but the bottom line is in stroke, when we have that type of stroke, we want to be able to open up the clot, the thrombus, as quickly as we can, and we ideally like to prevent another thrombus from forming. And sometimes what happens after stroke is that people can't move a leg, they're paralyzed, and they're more likely to form a clot in their leg. And so we're not only talking about clots that can cause bad things in the brain, but when the brain's had a stroke, you have clots in other places that you have to worry about and you have to treat.
Yes. That was interesting to me with the fibrinolytic therapy era in cardiology and then some of that translating to stroke, but it's clear that the heart and the brain are just different. Your window of opportunity is different. The concomitant therapies are different. Can you touch upon that just a little bit?
Sure. So first of all, not all clots are made up of the same thing when it goes to the head. So you can have clots that have been sitting around in the heart for a while that can be pretty firm and not as easy lysable like they're in the heart. They can have very much platelet-rich type of clots. You can even have calcium that goes up to the brain from the heart. So there's different, I would say the clots that we get are different in nature than in the heart, and therefore not all of them are maybe as susceptible to lysis, thrombolysis. And they may depend a little bit more sometimes on maybe on any platelet drug as well, or on the clot not, continuing to form or throw off new clots. So our treatments are a little bit different. I think also the blood vessels are different than the coronary, although we also now, as I was talking a little bit earlier, we're getting to a seismic shift in the world of stroke where devices will be complementing the lytic drugs much, much more, and we'll have some pretty good evidence coming out for that over the next year.
Great. And Bill, tell me, as far as the evidence, I see a lot of evidence that is not necessarily in an oncology population being used, whether it's prophylactic or treatment with anticoagulants. Do you think that we have enough evidence in oncology, or do we need to do more clinical trials because the patients are just different?
Yeah, I think it's a great question. I think that there has to be much more of a focus on long-term effects from cancer treatment. And so often our priority is on the disease before us, and we see people that come in with a recently diagnosed cancer, and the priority is doing whatever is necessary surgically or medically or radiation treatment-wise to try to eradicate that cancer. And there needs to be more focus on the long-term sequelae of treatment. And at the moment, we are not routinely prophylactically anticoagulating people post-treatment, but there may be times when that really should be seriously considered because for many cancers, it winds up being a comorbid illness that winds up being the cause of death and not the cancer, and particularly people that have certain risk factors for cancer. So considering patients that have cancers in the mouth and throat, head and neck area that are treated with surgically or radiation or chemotherapy, at least a third of those patients will die in the next 5 years from a cause not from the cancer itself, but from the fact that they may have had pulmonary disease from a tobacco history or coronary disease or cerebrovascular disease. There should be more of an emphasis on addressing that up front.
Yep. And something that the National Cancer Institute is aware of, and you foresee funding becoming available to answer some of these lingering questions?
Yes.
Excellent. Joe, what's the big unmet need from your perspective in neurosciences as far as thrombosis, its detection, its management?
First of all, it'd be nice to know where the clot came from and what the nature of the clot is. And because you would think that therapies could be more appropriately selected if you knew where it came from or what is made up. And unfortunately, 30 to 40% of the time, we have a stroke. We know the arteries are clogged in the brain, but we can't find the smoking gun. We can say, well, there's a little bit of disease in the neck, the heart's not pumping quite as well, but you don't see the clot where it came from. And for instance, if we knew it was the heart, we'd probably be tending more towards the anticoagulant side. And if it's in the neck, we probably are thinking more about antiplatelets. The other big issue is the balance between prevention of ischemic stroke and hemorrhagic changes and hemorrhage. And that's a safety issue. So we like to have antithrombotic medications that are effective and also as safe as possible. And it's always a two-edged sword. Sometimes the more effective medicines in preventing thrombosis have the bad side effect of also being higher risk for bleeding.
Yes. And is ultrasound part of that, an ultrasound-based lysis strategy? Do you see that assuming more of a role in the future?
Well, in terms of the acute changes, yeah, there's actually several different studies. One is using transcranial ultrasound to focus in where the clot is acutely in the setting of using lytic and other medications. So we'll see how that works out in real practice. We've used it intravascularly as well. There's probably better devices than intravascular ultrasound to get rid of the clot very quickly. Some of the new stent retriever devices and aspiration devices are actually pretty good. But one of the things we like to prevent is when we use these devices inside the artery that we don't fragment the clot and then cause another stroke in a different artery territory than we started with. So you want to get rid of the first one, but you don't want to make a second mess.
Yep. Well, it sounds like we've made some headway, but a lot more work yet to be done to be able to diagnose individuals at risk for thrombosis and having treatments that are both effective and safe.
Mm-hmm.
So I'd like to thank our guests today on Scholarvision, Drs. Barrett and Broderick. We touched upon a very, very important topic of thrombosis. And until our next program, keep asking questions. Inquiry is the true compass of science and medical advance.